Hello everyone, I am Hidenori Tanaka, the corresponding author, and he is Yuki Amioka, the first author of our paper published in GIE titled Diagnostic Value of Magnifying Endoscopy for Colorectal Laterally Spreading Tumor, Nongranular Type. We are pleased to discuss our paper. This retrospective study was conducted at Hiroshima University Hospital in Japan. And today we are joined by a special guest, Hiroti, the official mascot character of Hiroshima University. So, Dr. Amioka, could you tell us what led you to start this study?
Thank you, Dr. Tanaka. In our daily practice, we routinely perform magnifying observation because it has been reported to be useful for determining the treatment strategy. Laterally spread tumors of the nongranular type LSTNZ, especially the pseudo-debris subtype PD, are known to have a higher rate of carcinoma and submucosal invasion. Therefore, en bloc resection by ESD is recommended. Even for these lesions, we routinely perform magnifying observation prior to treatment. However, it remains unclear whether it truly contributes to treatment decision-making in LSTNZ. Therefore, we conducted this study to evaluate whether magnifying observation is useful for qualitative diagnosis and for guiding therapeutic decision-making in LSTNZ.
How did you design the study to address this issue?
We retrospectively reviewed LSD energy lesions rejected by ESD or surgery at our institution. We evaluated the magnifying endoscopic images and compared them with the corresponding histopathological findings. Magnifying NBI findings were evaluated according to the genetic classification, and magnifying chromoendoscopic findings were evaluated according to Kudo's pit pattern classification. We also assessed the treatment outcomes of ESD, including en bloc and curative resection rates.
Could you share the main findings of our study?
In the FE subtype, there were no deep submucosal invasive carcinoma. Lesions classified as genotype 1 were almost exclusively hyperplastic polyps or cecil-selected lesions, while type 2A or 2B lesions were mostly mucosal dysplasia. On the other hand, almost all PD lesions were categorized as genotype 2B. However, pathological diagnosis ranged widely from low-grade dysplasia to deep submucosal invasive carcinoma. Although all these cases of deep submucosal invasive carcinoma show multifocal submucosal invasion, magnifying findings were homogeneous within each lesion, and the invasive area could not be identified endoscopically. Regarding treatment outcomes, high en-bloc resection rates were achieved with ESD in both subtypes. Notably, all PD deep submucosal invasive carcinomas had invasion depths of less than 2,000 micrometers and were completely rejected by ESD.
So, magnifying endoscopy appears helpful in the FE subtype for distinguishing neoplastic or sessile-related lesions from intramucosal region, right? However, in the PD subtype, most regions will show JNet type 2B, which limits the value of magnifying observation as a diagnostic tool for assessing invasion depths. How about magnifying chromatography?
Magnifying chromoendoscopy did not provide substantial additional diagnostic value in either the FE or PD subtype.
Based on these findings, how should LSCNG be managed in clinical practice?
The first step is morphological recognition using indicocarbamine displaying to differentiate differentiate FE and PD subtypes. For FE lesions, management can be guided by genetic classification. Type 1 lesions may be followed or rejected endoscopically. Type 2A or 2B lesions should undergo endoscopic resection, and embark resection is preferable when feasible. In contrast, if a lesion is identified as PD, embark resection by ESD should be performed. Because magnifying endoscopy does not reliably identify the location of the mucosa invasion in these regions, its role in guiding treatment decisions appear to be limited, and it can be omitted in this specific context. In addition, magnifying chromoendoscopy is unnecessary for both the FE and PD subtypes.
Although magnifying observation is useful for the diagnosis of colorectal tumors, it still requires technical proficiency, and accurate interpretation also demands experience, which limits widespread adoption, particularly in Western countries. We show that the contribution of magnifying observation to treatment decision making is not uniform across all morphological subtypes. We hope that this strategy will contribute to the optimization of endoscopic practice. Thank you very much for this opportunity. Bye bye.
Bye bye.